the floor over. It's all yours, Arun. Yeah.
Thank you very much, Alok, and thank you for the invitation to speak this evening in my time. It's 7 p.m. at night in Melbourne. And the talk I'm giving today is entitled Sonographic Assessment of Lung Volume and Highlights from Preclinical Studies. And in this talk, I'll be talking about some of the potentials of lung ultrasound to fill some important gaps in neonatology. And then I'll be presenting some findings from preclinical studies that have been done at the Murdoch Children's Research Institute within Neonatal Research Group. This is an animal lab which is led by Professor David Tingay, and we study the large animal model of the preterm lung, which are preterm lambs. So today I'll be sharing the results from 4 studies that we've done in the last couple of years, which are all centered on how we can use lung ultrasound to assess changes in lung volume. I'd just like to say the last 2 studies are unpublished, but they're in the final stages of being submitted for publication and have been presented previously in conferences as well. So my contact details are down the bottom. There's my email address, my Twitter account if anyone would like to reach out and communicate. And without further ado, let's get going. So I'm sure all of us in this talk tonight are familiar with these x-rays. These are x-rays from preterm babies who've got severe lung disease, all of them mechanically ventilated. And at present, up until recently, in the last 10 years, chest x-rays were really the only tool that was readily available in NICUs. And we use them every day to assess lung volume. The most common practice is counting the posterior ribs. But they've got obvious disadvantages that I think everyone is aware of. That's why we're all learning lung ultrasound. And they expose babies to radiation. They take time. In particular, in Victoria, only 2 out of the 4 major tertiary NICUs have X-ray on site 24/7. So we're often waiting 20 to 30 minutes to get a chest X-ray after hours for babies. And the rib measurement in particular is actually known to be quite inaccurate when it's compared to actual gold standard measures of lung volumes in babies. That's not to say chest X-rays are not important. After their discovery in the late 1800s, 1895, there was huge amounts in the literature about how this was going to change medicine. But interestingly, it was only a year after their first discovery that people began to report the side effects of chest X-rays, radiation-induced dermatitis, deep tissue trauma. But these are side effects and disadvantages that we've put up with, I think, because we've had no suitable alternatives. There are gold standard measures of lung volume available, and they are used, but only in exceptional circumstances. So here we've got whole body plethysmography, which is the gold standard measure of lung volume, CT scan, which is a gold standard measure of lung aeration, and electrical impedance tomography, which is not a gold standard measure of lung volume, but is a promising non-invasive lung imaging tool, which has been validated against CT in adult patients. The disadvantage of EIT is that it still is largely limited to the research field in neonates. Most units don't have access to the EIT devices, and compared to all units having access to an ultrasound system which could perform lung ultrasound. So because of the limitation of access to these tools, or the fact that they're too cumbersome or they expose babies to really excessive amounts of radiation, as clinicians, we mainly rely on oxygenation to estimate a baby's lung volume. So in particular, in mechanically ventilated babies, when you're performing lung recruitment, you would use a baby's oxygenation to guide this. And we've all seen this clinically before, where you've done a lung recruitment maneuver on a baby, you're starting to wean the pressure, and all of a sudden your saturations fall and you've gone beyond the closing point of the lung. And this is because what you need is actually quite large changes in lung volume. And this is a figure from David Tingay's PhD, where he actually mapped the pressure volume relationship of the respiratory system in newborn infants on high frequency. And he showed that he first showed that they all had deflation limbs, but he also showed that you needed these quite large changes in lung volume, almost a 50% reduction in lung volume before you desaturated. So while oxygen is also used frequently to guide lung recruitment, estimate lung volume, it's not an ideal tool. It has disadvantages. So our research, our lung ultrasound research in particular, has been focusing on how we can use lung ultrasound to estimate and measure lung volume. So this is using it in a dynamic way where you're measuring the lung continuously rather than doing a single diagnostic image. And this is actually not a new concept. This man, Alan Hendon, has done some early clinical studies, which I'll go to. And the earliest studies showing that lung ultrasound can detect changes in lung aeration were in fact from the 1970s. So this was the first study, which actually showed that lung ultrasound can measure changes in lung aeration, which are occurring rapidly and in real time. This was back in the day where you just needed to be a single author to publish a paper. And in this study, Hendon, he used a combination of wet sponges and cadaver lungs, where he soaked them with different amounts of water, and with the lungs, he inflated them to different pressure increments. And he used A-mode ultrasound, which was the only type of ultrasound available at that time. And the way that works is it sends an ultrasound signal back, and then you can measure the amplitude of the reflected signal. And what he found, which is shown in this figure here, is as you inflated the lung, less and less ultrasound was able to transmit through the tissue, showing that the impedance of the tissue to air slowly increased proportionally with lung aeration. And when he modeled this using the cadavers, which are the cadaver lungs, which are inflated to fixed inflation pressures of 0 to 35 centimeters of water, he demonstrated this linear relationship between the lung ultrasound penetration and the overall aeration of the lungs. So this is all very promising, but as you can see, having an A-mode ultrasound doesn't really give you that much detail. And so there wasn't much further research into this field until recently. And I think this is because there's been a considerable development in the quality and the technology of ultrasound imaging. We've gone all the way from where the object which was being scanned needed to be submerged underwater so that you could get these A-mode ultrasounds, to these giant devices where patients having had to be lying down on a bed with this huge contraption on top of them, to these really highly detailed images of babies, and even 3D reconstruction images as well. So the current landscape of neonatal lung ultrasound has mainly been focused on diagnostic imaging up until recently, with most of the body of evidence being around pneumothorax transition, diagnosis of neonatal RDS and predicting surfactant administration, differentiating TTN from RDS, and probably most excitingly, the early prediction of BPD. However, using lung ultrasound to measure lung volume or lung recruitment is still in its very early stages. And our research program is using a combination of preclinical studies using the preterm lamb model and human studies, trying to really develop some more functional applications of lung ultrasound. So today I'll be talking about our preclinical research, what we found and where we think this is going. So again, like I said before, using lung ultrasound to measure lung recruitment is not a new concept. And like many things in neonatology, our adult counterparts in adult ICU are a little bit ahead of us. And this is probably the key paper which led to all our research, and I recommend as a read. So this group have demonstrated that in adults, you can use lung ultrasound to assess lung volume. So in this study, they studied 40 patients, 30 of them who had ARDS and 10 with acute lung injury from different causes. And what they did was they performed a randomized crossover study where they performed pressure volume curves using inbuilt ventilator software. And they did them at a PEEP of 15 and a PEEP of 0 and performed recruitment maneuvers at each stage. They performed lung ultrasound during each of those maneuvers, and they found a highly significant correlation with an increase in the re-aeration score and the amount of lung volume that was gained. What you'll notice here is that the volume of air that they are actually measuring is extremely large, so sort of 0 to 1400 mils, whereas the usual preterm lung volume is about 40, maybe up to 50 mil per kilo if you're very well inflated. So you can see that it's not really known whether these large changes in lung volume, which are proportionally smaller, in babies will be able to be detected with ultrasound. There has been a little bit of animal work which has been done, which has tried to validate this practice. So this group performed a study in an adult rabbit model of ARDS. So this was normal saline-induced ARDS, where they repeatedly washed out the lungs until they showed a reduction in gas exchange. And again, they performed lung ultrasound guided recruitment this time in these animals, and demonstrated that you needed much higher pressures to recruit the lung than you would if you were using the oxygenation. But interestingly, their lung injury markers were lower. But again, this is an adult model. It's a rabbit model, which is not as translatable in terms of preterm lung physiology. And this is where our model has come in. So in these group of studies, we've used preterm lambs. They were all delivered about 125 to 127 days gestation. So that corresponds to about a 23-weeker. At 28 weeker, but lambs actually have much more functionally immature lungs. And so their lungs are more similar to a 24, 25 weeker. In half of these animals, we have them on placental support. So this was a model first described by Noah Hillman and Alan Jobe. And what this model allows you to do is to keep the lamb's gas exchange normal, and so you don't have to expose them to any oxygen. And so because our primary goal is to investigate new ways to protect the lung in the delivery room, you can really tease out what are the factors which are leading to lung injury. We also monitor lung volume using electrical impedance tomography. And in all of our experiments, we've been performing lung ultrasounds at different stages. So the first study I'd like to share has been published. It's open access in Archives of Diseases in Childhood, the fetal and neonatal edition. And this study has been focusing on really trying to validate whether the changes in lung ultrasound scores do correspond with changes in lung volume, and if so, how precisely they detect lung volume. So this will be revision for everyone on the call tonight. This is the pressure volume curve and the real core concept of lung recruitment. So if you practice open lung ventilation in your unit while using high frequency ventilation, then you would be performing lung recruitment maneuvers on them to optimize their lung volume. And so if we just quickly run through this pressure volume curve, you can see the lung starts here at a very low lung volume and at a very low ventilator pressure. And as you slowly increase the pressure, you don't get much change in lung volume until you hit the opening pressure, which is this first dot here. And then you get rapid changes in lung volume until you approach total lung capacity. And then you start bringing the pressure down, trying to find that deflation limb and the optimal region of ventilation, which is usually a couple of centimeters above the closing pressure. But the problem in clinical practice is we're pretty good at finding the opening pressure, and we're actually pretty good at finding total lung capacity, because you can use a baby's oxygenation. You can actually use their heart rate and their blood pressure to tell when you've really inflated the lung as high as it can go. But we're not very good at finding this optimal region of ventilation. And that's because of what I spoke about earlier, is that you really need quite large changes in lung volume before you can get changes in your saturations. So when we're using our saturations and we're turning down the ventilation pressures, we wait for the babies to desaturate. And unfortunately, that's usually around here, sort of well beyond the closing pressure. And at that point, we've lost a lot of lung volume. So then what you have to do is turn the pressure all the way back up again and then pick an arbitrary point above the closing pressure. And usually that's 2 to 3 centimeters. Now, lung ultrasound, as you've probably heard, is really sensitive for picking up atelectasis. even though it's not very good at detecting hyperinflation. And because of that, we've hypothesized that lung ultrasound will be very good at discriminating this deflation limb and also identifying the closing pressure, hopefully before you get massive changes in lung volume. And that's really the key of all of our studies and what all our research has been centered upon. So I'd like to share a video. So this is of a baby who's got severe RDS, secondary to surfactant deficiency. They're initially on conventional ventilation, and we're putting this baby onto high frequency in our unit. So in our unit, we practice open lung ventilation, and we perform the lung recruitment maneuver immediately after transitioning the baby to HFOV, unless they sort of immediately come down to air. So what you'll see is the settings that the baby is on in the bottom left-hand corner. I'd really like you, though, to focus your eyes on this region here. So you've got the chest wall just here, the ribs, and then the lung pleural region, or the pleural surface up there. And that's where you're going to see most of the changes. Here you can see the liver just coming in on the right-hand side of the screen. So we're scanning the dependent lung, the lower lactal region. If I play this video, you can see this baby is now on conventional. We're now on high frequency, a mean airway pressure of 12. There, the baby just took a breath, and we're up to 14. Now up to 16. You can see how that collapse is slowly starting to resolve. Now up to 20. So we're using the baby's oxygenation to guide this maneuver, and the lung ultrasound is just observational. There you can see the collapse is almost completely resolved, and we're coming down. And really just focus on that surface of the lung, the pleural, where you would expect to see the pleural line. Here we thought the baby began to collapse on ultrasound around 15, 14, but in fact they had not desaturated yet. And because we're not using lung ultrasound clinically to guide recruitment, we kept going down. You can see now we're down to 11. So this is where the baby desaturated. And so we went all the way, kept going. And then after this, we went all the way back up to opening pressure, which was 24, and then stopped at 11. And you can see there, compared to that first image, if I just play the video again, compared to that first image, there's far less collapse once we had finished the lung recruitment maneuver. And we had done this a few times by this point. And we thought that this was a good sign that lung ultrasound potentially is detecting the changes in lung volume which occur during lung recruitment. However, there hadn't been any studies which had specifically validated this against a very robust gold standard measure of lung volume, which led to the first study in a series of studies that I'm presenting today. So in this study, we used the preterm lamb model that I previously described. So we studied 20 preterm lambs. And in our model, we calculate their static lung compliance at the end of every experiment by reconstructing a pressure volume curve using the super syringe method. And so the way that this works is that all the lambs are intubated with a cupped endotracheal tube, and we have a calibrated glass syringe, which is about 200 or 250 mils in volume, depending on the size of the lamb. And this system is connected through a closed loop to the endotracheal tube and has a pressure manometer as well, which gives us pressure in centimeters of water. And what we do to reconstruct the pressure volume curve is we inject known volumes of air to predefined pressure increments of 0 to 35 centimeters of water. And because you can measure exactly how much air is going into the lung to specifically what pressure, you can reconstruct a pressure volume curve. So this is also a gold standard measure of lung volume, but it's not performed in young babies, in neonates, because they don't tolerate prolonged periods without tidal ventilation. It is actually done in adults in some centres using these massive glass syringes, but in our field, it's only used in animal research. And so in this study, during this pressure volume curve mapping, we performed lung ultrasound of one region. We decided to choose the right lower lobe because it was more accessible, and in the lambs, it actually inflates quicker. And we took images from each pressure increment. So we collected 260 lung ultrasound images. All of the images were de-identified and reported by an investigator who was not in the experiment, completely blinded to the pressures and volumes. We used a slightly expanded lung ultrasound scoring system. So this is heavily based on the work of Francesca Raimondi, Danny DeLuca, Nadia Youssef, the pioneers in neonatal lung ultrasound. It's based on their semi-quantitative lung ultrasound score. But because we observed that a lot of changes were occurring in the extent of collapse, rather than going all the way through to a normally aerated lung, we added in a couple of extra scores, which were really trying to capture differences in collapse. And so we defined that as greater than 50% of the lung field being collapsed or speckled, or less than 50% of the lung field. And we thought at the time that hopefully should give us enough resolution to detect changes in lung volume. So this is a video of the whole procedure happening. So this now is in a lab. Again, you can see the chest wall. Let's get my pointer just to make that clear for everyone. So you can see the chest wall here, a rib, the pleural surface. This is all collapsed lung and a bit of lung artifact down here. The liver's down in here, that's the diaphragm. And in this video, the pressure that the lung is being inflated to will pop up down the bottom in white text. So I'll just play this video. So we're just now starting at 0 centimeters of water. The lambs aren't breathing, they're completely anesthetized. So now we're up to 10. So opening pressure in these lambs is usually around 20, which we hit now. And here you can see the lung rapidly snaps open, and you can see bits of collapse resolving. This is up to the maximum pressure. And then as you come down, you can see that the extent of collapse is far less than if you were to compare it to the corresponding inflation pressure on the inflation limb. I'll just play that video again because it all happens quite quickly. So you can see here we're at 0, now at 5. So there's really not much lung volume change occurring below opening pressure, and that's normal. Up until we hit 20, sorry. And then the lung snaps open, and you can just see this area here where the collapse resolves. And then you can see as we come down. So these are very short pressure increments. So we hold the pressure until we can see the pressure stabilizing in the manometer, or because we don't want to be there all day doing the pressure volume curve, we stay for about 30 seconds before moving on to the next pressure increment. So we found that there was this moderate significant correlation between the lung ultrasound scores and the actual lung volume that was being measured. And that's demonstrated by this figure here. So the dashed gray line is the lung volume measured from the super syringe, and the solid black line is the lung ultrasound scores. The open shapes represent the inflation limb, and the closed shapes or the solid shapes represent the deflation limb. And as you can see, where you've got small amounts of lung volume change below opening pressure, so this is only about 7 mil per kilo of lung volume, there's really no change in the lung ultrasound scores at all up until you hit opening pressure, and then you get these rapid increase in scores, and then you can see as we come down, the lung ultrasound scores rapidly drop as you hit the closing pressure as well. There's probably a little bit more resolution in this deflation limb. However, you can see the curve is quite blocky. This is probably because we were only scanning one region, and therefore the score could only be out of 5 rather than potentially out of 20 or more if you were scanning more regions. What we also found is in the majority of the animals, all of them except 2, the lung ultrasound was able to identify hysteresis, or the phenomenon where once the lung is recruited, as you're deflating the lung, you get a higher lung volume given the same amount of pressure compared to the inflation limb. And what we showed, and what that looked like on ultrasound, was the lung ultrasounds looked much more aerated compared to the inflation point, the inflation limb. So here's an example of that. This is 20 centimeters of water on the deflation limb and 20 centimeters of water on the inflation limb, where you can see much less collapse as you come up. So we thought this was very promising. We showed that it could detect large changes in lung volume, which were occurring very rapidly. But the visual scoring system was limited. And you saw that in that previous figure, in that it was very blocky. It really wasn't detecting much change in lung volume until you hit opening pressure. And we thought that rather than being a limitation of lung ultrasound itself, it's a limitation in the way that we've chosen to report or score our lung ultrasound images. And here's an example of that here. So classically, when you use the cited lung ultrasound scores in the literature, to get the worst lung ultrasound score, you need to have more than a centimeter of collapse. Some places report half a centimeter of collapse to give you the worst lung ultrasound score. And here are 3 images which are taken from different animals, different babies. Sorry, this is from one of our clinical studies, where they all have very obviously different extents of collapse. So this baby has got this tiny pocket of collapse here. This child has got very extensive collapse, but it's the same sort of depth. And then this baby here has about 0.4 centimeters of collapse, so very extensive. But if you were to use any of the lung ultrasound scores, including the ones that we have described, oh, sorry, there was a question. I missed whether it was the map or the PIP. It was the map that was being increased. If you're talking about the first video that I showed, the baby was on high frequency. So as you can see, because none of this collapse is more than half a centimeter, actually, if you were to score this in a research setting, all of these images would achieve the same score. So you can immediately see where a visual scoring system is lacking, is that we just cannot have enough scores or an objective way to quantify this amount of collapse to get a true continuous measure. So that's what led us to perform our next experiment, because we recognized the limitation of our scoring system in the lab, and we wanted to see if we could find a more objective way to quantify lung ultrasound images, something that was easy to access and something that's reproducible, and ideally gives us a sort of broad range continuous measure to capture these smaller changes in lung volume. And so we turned to using computer-assisted image analysis. And while this sounds very complicated, everything that was done in this study was done using open access software, which is freely available. The paper, which was published in Pediatric Research, is also open access, as is all of our methodology as well. So the way computer-assisted image analysis works is you can use software to measure characteristics of an image, and you can measure a lot of things in terms of the brightness, how many pixels there are in the image, how different the pixels are from each other. You can really get a lot of measures. And for this first experiment, we decided to stick with a simple measure of grayness, or the mean gray value. And the way this is calculated using the computer software, the software's called ImageJ, is you can take any image. It doesn't need to be an ultrasound image. It doesn't even need to be a color, black and white image. You can just convert the color image to black and white, and you select a region of the image for the software to analyze. And what it does is it takes the individual pixels and it measures how gray it is, or how black it is, or how white it is. And the scale ranges from 0 to 255, 0 being black and 255 being white. And that's because this software processes the images in 8-bit. So you have 256 bits that can be assigned to a shade of gray. And so they start from 0 and they go to 255. And so you can see that's a much greater scale than any lung ultrasound scoring system that's available in clinical practice. So what you do is, the measurement that we chose was the mean gray value of the region that was being studied. So in this example, in this yellow box that's been drawn over this image, the computer software will measure the individual gray value of each of the pixels and then divide it by the total number of pixels which is within that region of interest. And here you can see this is a lung which is quite collapsed, and you can see the mean gray value is 119. So then if you were to take this lung and inflated all the way up, what we see as clinicians is that lung image getting brighter, that pleural line getting more solid, that speckling appearance disappearing. And that actually corresponds with an increase in the mean grey value, because overall the image gets brighter and all of the pixels get brighter. So if I go back to that collapsed image, you can see here you've got this distribution of grey values, which is centered around the middle with a mean value of 119. And then as the lung inflates, the distribution of mean grey value skews towards brighter, and the mean grey value had increased from 119 to 162. So again, we sought to use the same methodology to provide some validation for this specific measure. So this time we decided to study 40 preterm lambs, because if you recalled previously, we only scanned the right lower lobe in the previous experiment, and we wanted to see whether we could see differences by scanning different regions of the lung, and in particular, different gravity-dependent regions. We performed pressure volume curve mapping as we did in the last experiment, using the super syringe method with a manometer, and we performed simultaneous lung ultrasound at each pressure increment. So this time we acquired 520 images, all of which were de-identified and randomized, and then the image analysis was performed blindly by 2 separate investigators, this time offline. This was the region of interest we chose. We based this on some previously published research about the normal pleural line thickness in healthy infants, and they said that anything less than 1 millimeter would be considered normal. And so we defined our region of interest as the surface being the surface of the lung, the lateral margins being the rib shadows, because we didn't want to capture these darker pixels, which are due to the ultrasounds not going through. That would have interfered with the measurements. And then we measured 50 pixels down and just followed that superior margin to pick our region of interest. And that corresponded to about 1 millimeter in depth on the ultrasound image. So again, we found a moderate correlation between the mean grey value and the lung volume. So these figures are the same. So you've got the dashed grey line, which is the lung volume, the solid black line, which this time is the mean grey value or the image analysis methods. And again, we were able to reconstruct these really nice pressure volume curves, both from images in the dependent lung, the right lower lobe, or the right lower lateral region, and the non-dependent lung, the right anterior upper region. But what was more exciting about this study is, rather than having that sort of flat line at the low lung volumes and then it only changing once you got above opening pressure, we were actually able to detect much smaller changes in lung volume that were occurring at the lower end of the pressure volume relationship using this image analysis software. And we think that's a reflection of the type of measure itself. You've got a lot more steps in the measure. It's a true continuous measure, and 255 shades of grey is much more than the human eye can perceive, even in optimal lighting conditions. So again, we thought this was promising. There were some limitations to this study again. So all the analysis was performed offline. So it's really not something that can be done in clinical practice yet, because you've got to do your images on the baby and then go away and sit at a computer. So I think automation is going to be something really important. The other difference is those of you who are familiar with ultrasound may have realized that if you're measuring the grayness of an ultrasound image, that's going to be influenced by your ultrasound settings as well. So things like the gain and the compression. And in this experiment, we kept those exactly the same between all of the animals, but whether it's actually translatable across different ultrasound systems, so if you were to do the same measure using different systems, is yet to be elucidated. So again, there are other measures which are available, which are independent of ultrasound settings, but they haven't been explored just yet. Francesco Raimondi's group have performed a study using some of these more advanced measures, but they used them in relation to oxygenation and need for surfactant. But that's a very interesting paper, which I can share the reference to. The third experiment that I wanted to talk about is one of our more recent ones. And this one is really looking at whether lung ultrasound can detect regional aeration in homogeneity. And we think this is really important because there's a growing body of evidence that it's not only important to aerate the lungs, to reduce lung injury, but it's very important to aerate the lungs evenly. And when you've got areas of collapse and areas of hyperinflation, in fact, that can be more harmful than just having a single area of collapse. And unfortunately, just like chest x-rays, just like everything else in neonatology, we don't have very good tools which can tell you whether a baby has actually got inhomogeneous lung aeration at the bedside. You can use electrical impedance tomography to detect this. It's actually very good at detecting this. But unfortunately, again, it's not readily available in most neonatal intensive care units. So this is a cross-sectional image of the lung. And this is what EIT actually looks at. So EIT is a soft electrode band which wraps around the chest, and it gives you this single slice cross-sectional image across both lungs. Usually the pixel resolution is limited to 32 in babies. So it depends on how many electrodes are actually on the belt. But from that, you can look at the gravity non-dependent areas and the gravity dependent areas, both of the right and the left lung, which is why we use it in our lab and we use it as our form of lung imaging monitoring. So in this study, we wanted to confirm whether the observed differences that we were seeing in lung ultrasounds actually corresponded to inhomogeneous aeration. And these set of images were taken from one animal that was mechanically ventilated. And these top two images are taken from the upper right and left anterior regions. And these bottom two images are taken from the lower lateral regions. We find that you can only actually take 4 images in a lab just because they've got quite pigeon-shaped chests. And so you can really only get sort of the upper anterior and then the lower lateral regions just because of the shape of the chest. And what we did was, in this study, we studied 32 preterm lambs this time. All of the lambs were actually mechanically ventilated on targeted tidal volume ventilation. They were still on placental support, and we performed lung ultrasound after 15 minutes of mechanical ventilation. We performed lung ultrasound of 4 regions, and we performed simultaneous electrical impedance tomography. Once again, just to keep it robust, we took all of the 128 images, we de-identified them and randomized them, and had them reported using that lung ultrasound score that I showed previously. So this image here is showing that EIT image again, but it's showing what the lung ultrasound images were corresponding to. So if you're scanning the right anterior upper region, that corresponds to the ventral gravity non-dependent lung. And when you're scanning the lower lateral region, that corresponds actually to the central lung, because most of the lung in humans and lambs is made out of the central lung regions, with the dorsal regions just being these small proportions down here. This is what we found in the EIT. We calculated the aeration ratio. So we know what the expected aeration in a healthy aerated lung should be in a preterm lamb. That's based on CT studies. And what we did was we compared the measured aeration to the predicted aeration of each region. And what that was able to give us was an aeration ratio, where an aeration ratio of 1 is ideal. An aeration ratio greater than 1 is relative over aeration or hyperinflation, and less than 1 is atelectatic or under-related lung. And as you can see, these lambs develop very inhomogeneous lung aeration very quickly. This is probably faster than it occurs in babies, and it's probably because the lambs are bigger for their degree of lung illness. So if you can imagine, if you've got extremely surfactant deficient lungs, that's usually in babies who are very small, and therefore their lungs are less gravity dependent because there's less mass. But in the lambs, they weigh about 3.5 to 4 kilos, but have the same, if not more, degree of surfactant deficiency, and so their lungs are a lot more gravity dependent. We found that the lung ultrasound scores again corresponded with these differences in aeration that we were seeing, where the higher lung ultrasound scores actually reflected hyperinflation, and the lower scores represented atelectasis. And again, we used our image analysis tool, and as you can see, the lung ultrasounds didn't really detect the differences, although you can see it in the raw measurements. They weren't statistically significant in the left region. All of the differences detected by the image analysis were statistically significant. So here you can see the anterior upper regions are higher compared to the right lateral lower regions. And again, we thought this was very promising. It sort of confirmed that those differences in lung ultrasound scores you can see within each babies are likely to represent inhomogeneous lung aeration. Again, this was an animal model. It was they were ventilated animals on placental support. We're unsure what prolonged periods of placental support do in terms of retaining lung liquid. So there's still a bit more work to be done in terms of translating that into clinical practice. The final study that I was talking about is the most recent study that we've recently completed, and we're hoping to publish in the next couple of months. And this is using lung ultrasound to measure lung volume during mechanical ventilation. So if you recall from the first two studies, the lung ultrasounds were performed during static in vivo pressure volume curve mapping. So those lambs weren't mechanically ventilated. They were just being inflated to a fixed inflation pressure. And that again is a significant limitation because we don't do that in babies. And what we're really interested in is what is a lung volume we can measure during tidal ventilation, conventional ventilation. So in this study, we studied 19 preterm lambs. These were much longer experiments, which were done off placental support. So this is more reflective of what happens in clinical practice. So all of these lambs got delayed cord clamping. They got a dynamic open lung maneuver immediately at birth, and then they were mechanically ventilated on targeted tidal volume for 90 minutes. And again, this was part of our larger group of experiments which our program is investigating. We performed lung ultrasound on all of the animals every 15 minutes and simultaneous electrical impedance tomography. We did imaging of 4 lung regions. Again, we think that's fairly comprehensive of the entire lung based on the animal's chest. And we acquired 532 lung ultrasound images. Again, we took all of those images, we de-identified all of them, randomized them, and we had them reported using that previous lung ultrasound score, which was validated against the super syringe. So more promisingly, we found that once you used a more comprehensive lung ultrasound score, where you incorporated imaging from the gravity-dependent and non-dependent regions, we found this highly significant and strong correlation between the lung ultrasound scores and the measured lung volume in mil per kilo. Interestingly, it looked like quite a linear relationship. In some areas, especially around the middle regions, the distribution of lung volume was pretty wide. And in fact, it was only above 50 mil per kilo where we began to see the more normally aerated lung, which is interesting because there's been recent work published which has shown that preterm infants with surfactant deficiency actually have ongoing demonstration of lower lung ultrasound scores or less aerated lungs throughout their stay. Because there's literature published of using both the semi-quantitative lung ultrasound score and also more simple lung ultrasound scores, which maybe only incorporate image from one region on the left and right side, we decided to compare how each of those different combinations performed. And sort of somewhat expectedly, when you incorporate all of the regions, you get a much better performance compared to when you do selective regional imaging. So these figures here are box plots showing if you only looked at the right-hand side, to the right lower score. And again, this was very similar to what we found, almost exactly the same in our first animal study. It gets a little bit better if you compare imaging from both sides. And the same if you image the gravity non-dependent region, although interestingly, the non-dependent regions were less reflective of true lung volume. I think even more importantly, we also compared this to oxygenation measures. Because of these animals were all off the cord and they were being managed for longer periods, we also did regular blood gas sampling. And so we were able to calculate the oxygenation index, the SF ratio, the saturation to FiO2 ratio, and the alveolar arterial gradient. And we found that, promisingly, the lung ultrasound outperformed all measures of oxygenation, even though the oxygenation index performed pretty well, 0.54, the lung ultrasound scores were much better at actually predicting lung volume. And this may explain why lung ultrasound is so good at certain things in terms of, predicting which babies are going to need surfactant. It may explain why using more comprehensive lung ultrasound scores is better at predicting BPDs or works better in inhomogeneous disorders. And again, highlights the promises of lung ultrasound as a functional imaging tool in the unit. So from this body of work, we've concluded that lung ultrasound can detect rapid and real-time changes in lung volume, and the real limitation on estimating lung volume is in the type of scoring system that you use rather than being a limitation of lung ultrasound itself. And this can be improved using more objective measures, in particular computer-assisted image analysis. We've also shown that regional differences within each patient of lung ultrasound scores most likely represent regional aeration inhomogeneity. And we think that's important because there's a potential there to further delineate which babies are going to go on to develop lung injury. And we've also shown that comprehensive imaging, which incorporates images from the gravity non-dependent and dependent region, is more precise at detecting changes in lung volume compared to simple lung imaging, simple lung ultrasound, and your oxygenation metrics. So I'd like to conclude there and also acknowledge the huge team that goes into looking at doing these experiments. So my supervisors for the PhD, my lab team, my clinical research team, of course, my family, medical and nursing colleagues, and the families and babies who take part in our clinical studies, which I haven't spoke about today. Thank you.
Thank you so much, Arun. That's fantastic. I mean, it's an amazing piece of work, which obviously, is going to contribute hugely to our ability to be able to use lung ultrasound in practice. We have a few questions coming in from the audience. So have you considered surfactant as an intervention in your work?
Oh, yeah. Yeah, so in the model, it depends on the experiment. For the short 15-minute experiments, the primary purpose of those are to investigate specific delivery room respiratory support strategies. And so in practice, in Australia at least, most of us wouldn't give delivery room surfactant unless the babies were in extremis. So those short 15-minute studies, the animals don't get surfactant. But for the longer 90-minute ventilation studies, they do get surfactant. And they get it at about 20 minutes of age in the study.
So one question that I had in particular with regards to the recruitment maneuver and how we use it clinically, because I think the one challenge that you have is you are recruiting an area of the lung that you think is atelectatic, but where you kind of had homogeneous lung disease like RDS, that may work. The worry is when you have inhomogeneous disease and what's happening to the normal lung. So your experience of pneumothoraces and how you deal with normal lung in situation like that. Did you see a lot of pneumothoraces with the animal models or?
Not in the PV curve studies. We don't take the original description of the PV curve inflated the lungs up to 50. And with that, there was a higher incidence of pneumothorax. At 35 after 15 minutes of ventilation, though, we don't see pneumothoraxes. In fact, they're a little bit more common in the 90-minute animals, but not that high. Again, because all the animals get surfactant, we're intentionally using more lung protective ventilation strategies. And that's what we see in clinical practice as well. We hardly ever see late pneumothoraxes, and even when performing lung recruitments. And you can make an argument that if you've got inhomogeneously aerated lung, you're actually at higher risk of developing pneumothoraxes because the gas volume will preferentially be delivered to the aerated lung and not to the collapsed lung. But the whole idea, I think you highlighted another thing is that lung ultrasound is not very good at detecting hyperinflation. And when you perform a lung recruitment maneuver, say in a baby with established BPD, you are going to hyperinflate some areas of the lung. So I guess the argument for doing it is that, well, you're briefly exposing some areas of the lung to high pressure while aerating the other areas. And in the end, you'll be left with a more homogeneous lung.
That's really helpful. Obviously, the message to the group, because we just discussed this last week. We had a talk on recruitment maneuvers and how to do it safely. And I think, one of the kind of concepts in that was obviously just making sure that we're keeping a clinical eye on the baby, because in clinical practice, if the baby's desaturating, is there something else in terms of heart-lung interaction, blood pressure, that's altered things. So we have a question from Dr. Leila. How long does the recruitment effect last in these animals in relation to oxygen saturation? So once you go up a certain pressure, I mean, it looked like seconds literally, but yeah, yeah.
Yeah, so the PV curve was done on placental support, and that was a specific procedure to map the pressure volume relationships. So the saturations aren't measured in that time, and so we weren't using oxygen to guide it. And that's the same in our 90-minute experiments. The lung recruitment is done at birth. It's just based on arbitrary pressures, and it's not guided. In terms of the lung volume, we almost see the lung volume changes instantly on lung ultrasound. Sort of the moment it begins to recruit, you'll see it. And based on our sort of observations, which is still currently being studied, we think we can say the changes in collapse a lot quicker than you can see the changes in oxygenation. We're actually in the process of conducting a study which is registered on the Australian Clinical Trials Network. I'm happy to share the link. It's a study looking at 20 babies who are all on high frequency ventilation, and they're getting oxygenation guided recruitment maneuvers. And we're actually going to be performing a full lung ultrasound of 6 regions at each pressure increment as well. So we're hoping that'll answer some of those questions in terms of the relationship between the changes in lung ultrasound scores and oxygen saturations. I can see there's another question there from Margarita. Can you use open lung ventilation on conventional? Yes, you can. You can do it. It's not done as often, but it can be done by setting your tidal volume. And then what you do is you use the PEEP to perform the lung recruitment. What you do is you just ramp the PEEP up as you would do using the MAP in high frequency. And because you've got volume guarantee, your delta P should stay the same as you do the recruitment maneuver. Obviously, that's going to probably expose the baby to even higher pressures than if you were on conventional, because to preserve that tidal volume, you would need to have much higher PIPs as the PEEP goes up. Do you not see A lines in the lung parenchyma? This is something we may consider to measure lung recruitment. That's an excellent observation. We did note that the majority of lung volume change was observed in that lower region of lung ultrasound scores, so the resolution of collapse. And if you remember that previous figure I showed, we did eventually see A lines in those more longer studies, but that occurred with time rather than with pressure. And we think that A lines are more reflective of lung liquid clearance and not gains in lung volume. It's very hard to measure lung liquid though, using EIT. It's very challenging even with the synchrotron to tell the difference between atelectatic lung and lung liquid. So that's purely a hypothesis. The MAP was relatively high. Any idea of an equivalent MAP in human babies? Is that referring to that video of the baby having the recruitment maneuver, or the PV curve pressures of 35? If it's the first study, yes. No, I don't have an equivalent MAP between babies and lambs. It's not really mean airway pressure, it's just delivered pressure, because that's a static in vivo pressure volume curve. And so there's absolutely no tidal ventilation. And that's so we can actually measure the lung mechanics, because it's one of our outcome measures in the animal. So I don't know what the equivalent MAP would be. I guess from clinical observations, most babies need MAPs of higher than 20 to properly recruit up. But I don't know what the equivalent MAP would be for a baby. I suppose even babies have different MAP requirements. You know, a smaller baby may need less MAP to recruit. An older baby with more scarred, stiff lungs may need much higher pressure to open up their lungs, different pathologies. need different maps. And I suppose that's the whole point of using something to guide you, whether that's oxygenation, whether that's imaging. That way you can individualize it to the patient.
There's a question from Sujit.
Yeah, the presence of PDA. That's great. I actually really love that question because that's another area of interest of mine. I think the answer is we don't know. I think there's some good evidence now that significant PDA do affect your lung ultrasound findings. It's probably the lung edema, and that probably is the B lines and sort of the white lung artifact that you can see. What I can say is that at least in the lamb study, they all absolutely definitely have a PDA. So there were no animals with no PDA. And we know that because we do autopsies on them afterwards, and it's immediately after birth. But that's a very interesting question. I think there's a case series published by Patrick McNamara where they did lung ultrasound pre and post duct ligation. And that was really interesting. They showed that the ligation improved the scores. And I think there's also been some work done from the European group on the use of diuretics and the changes in lung ultrasound scores as well. So all I can say is that's a really good question. We should look into it further.
One question from me, Arun, just in terms of evolving chronic lung disease in your rabbit model, recruitment maneuvers and kind of ventilation strategies, and did we look at the long-term outcomes of lung disease in these?
No, so in this lamb model, this is a short finite model where the lambs at the end of the experiment, they're euthanized. We don't have the facilities to care for the lambs long term. They do that in some areas around the world. And it wouldn't be a true model of BPD because you'd really have to injure the lungs to develop that. And what we're doing primarily is exploring more lung protective strategies in the delivery room. And we want to know specifically what delivery room interventions are leading to lung injury. So if you kept the animals alive for months and months, there'd be too many confounders to really tease that out.
That's absolutely fantastic. Arun, I'd like to take this opportunity to thank you for your time. For what was an absolutely excellent talk. I have a request from Nadia and Adele. They weren't able to attend your session. Are you happy for me to share the video with them of the session?
Yes, of course. Yeah. Just the caveat that the last two presentations are unpublished, but they're at the stage where we're presenting them at conferences. So
we won't be publishing the video live. I'll just be sharing a link to the video from my Zoom, basically. But
yeah, sure.
Amazing work. And I mean, clearly for anybody who is thinking of doing lung research, especially lung ultrasound, I think, I think Arun is at the forefront of kind of leading this at this particular point. Arun, one question that I had, so in terms of your lung ultrasound training, do you think animal models have any role? I mean, and obviously that's a challenge because you need a kind of a wet lab for things like that. The other question is phantoms and how useful you think they are. Yeah.
I think phantoms are very useful to help people who are starting with lung ultrasound to understand what you're looking at are artifacts. So you may have heard we regularly in ASIM use a model where we have some sort of animal rib, it can be beef, pork, chicken, whatever, and we use different sponges, and what we do is a dry sponge is dry lung, and we just progressively wet the sponge, and then we gouge out bits of the lung and put liver in it, and we find that's really good at showing what you're looking at is just artifacts most of the time, except unless the lung is completely collapsed. Because you can reproduce all of the aeration patterns just using these things that you can buy in the store. I think the phantoms for lung ultrasound are really helpful because you don't need to have access to a lot of patients when you're first starting. You can just say, look, this is how it's done. This is how you can do a longitudinal versus a transverse view. I know some people actually use their hands, and so they hold a wet sponge and they scan over their knuckles, and so the knuckles represent the ribs, and the tissue between your knuckles is the intercostal space, and it works really well actually. And then you don't even need meat, you just need a bunch of sponges. So I think there's a good role for phantoms. In terms of animal lab experiments and lung ultrasound, I think it's really good to really make you try and understand how some of these patterns are occurring, but in particular how they relate to different physiological lung volume states. I think that's what I've learned most from it, because you can see the lung from complete collapse to full over aeration and see how the lung ultrasound findings change throughout that aeration spectrum. And I think doing research clinically in lung ultrasound is a great way to introduce it into your units as well, which is how we got it very much ingrained into our practice at Joan Kerner in Western Health. Is we're running 2 lung ultrasound studies at the moment, and that means your colleagues are exposed to a large number of lung ultrasounds which are done for research purposes, and that will inevitably creep into clinical practice. People will just start picking up the probe more, doing more scans. I hope that answers the question.
Yeah, beautiful. And I mean, just one last one was, is there any kind of work being done on kind of recreating animal models of pathology like pneumonia, meconium aspiration, which obviously, you can't necessarily predispose to and get, but I'm just curious.
Yeah, so there's a physician, a neonatologist named Doug Blank. He published some of the earlier lung ultrasound work in the delivery room, and one of his studies was in a group of lambs that had a high rate of pneumothorax, and he sort of confirmed that the same findings occur in preterm lambs. The group at Monash also are doing lung ultrasounds on models of TTN, where they're adding lung liquid back into spontaneously breathing term lambs. They've presented that work recently. And other than that, I think Danny DeLuca's group have done a lung ultrasound study in a mouse model of BPD as well, which was oxygenation-induced BPD. And they did histopathology confirmation of BPD, and also compared that to lung ultrasound findings and showed similar findings to babies with BPD to their animal model. I'm not sure about meconium aspiration. Usually the meconium models are either rabbits or pigs which have been given newborn meconium. I'm not sure if anyone has done any lung ultrasound particularly, but I could be wrong.
That's really kind. I'm really grateful. I'd like to take this opportunity to thank you and thank everybody who's here, on a Sunday for what has been a fantastic talk. Thank you so much, Arun.
No problem. Thank you for having me. Bye.
Bye.
Thank you. Bye.